So on the way to the job, we'll be considering factors like access and egress, if there's any bystanders or aggressive bystanders, as well as any other dangers towards me or my offsider. We're about 20 minutes away from hospital, and we'll be having another look at the patient as we enter the room. When we enter the room, while I'm listening for breathing, I want you to set the defib up and set it on manual mode, 360 joules, and start getting the defib pads ready. And then we can decide whether it's a recess from there. So as we approach our patient, we're looking for any obvious trauma deformities. We're also looking for any bystanders or any toxins, like empty pill bottles. Hello, sir, can you hear me? Not responding to voice. Not responsive to pain. Checking the airway. Airway looks clear. Listening, looking, feeling, breathing for 10 seconds. So it's not breathing. Starting CPR. Could you call an R50 for me? And charge.
AG1 calls, confirming R49, requesting R50 backup.
Copy. 20 minutes.
Alright. BT shock.
Shocking.
So that was at 25 seconds, so next shock is at 2:25. So once you've got the airway in, we'll test it, then I'll get you secure it. And then we'll move on to 30 to 2. So we'll be using the bag valve mask with reservoir bag at 10 litres per minute.
5, 4, 3, 2, 1.
Good chest rise. This will hopefully reverse hypoxia. We're also looking at other HS&Ts like hypovolemia, which we'll be doing a trauma sweep soon to look for any bleeding, although we cannot see any massive bleeding at this moment. We'll also be considering hyperkalemia and hydrogen ions, which we can reverse if we get ROSC. However, until then, we'll be moving on. We're also considering toxins, but however, if we do not smell any gas or see any empty pill bottles.
5, 4, 3, 2, 1.
Alright, so we'll be doing a 30 to 2 ratio now. If you could just count me down. We're also considering a cardiac tamponade. However, we can't do anything about that in the pre-hospital setting. So in about 25 seconds, we'll be shocking again. So in about 15, could you charge for me? We're also considering tension pneumothorax.
25, 26, 27, 28, 29, 30.
Charge. So we'll swap over CPR. So you'll take over after the shock. VF shock. So you can ventilate, well, I'll still take. So that shock was at 220. So what we will do is we'll shock next at 420.
29, 30.
Good bilateral chest rise with air entry, so we can rule out tension pneumothorax. Now I'll be doing a trauma sweep. So there's no blood underneath the neck. There's no obvious deformities on the neck. There's no deformities on the arms. There's no blood underneath. You can't see any bruising or bleeding on the abdo, and it's not distended, and it's not stiff. There's no blood deformities on legs, as well as on the other arm. So what we will do is, when we get to 420, I'll push charge, and then I'll get you to dump or shock again, okay? You've got a good rate going, good release, and we're going into the chest, so that's good. So I'll ventilate for you, just count down for me.
25, 26, 27, 28, 29, 30.
Good chest rise. We're also considering a thrombus, so the patient looks to be about 60 years old and it's got yellow fingers and got the seasonal cigarette packets over there, so it's possible this person is an ex-smoker, which would increase the risk of a thrombus. So I'll just come around here and put a charge for you. So if it's not shockable, I'll just get you to dump that for me. And then I'll start CPR. Assist, dump. So we're also considering the patient's medical history. However, we don't have any bystanders and we can't see any discharge letters. And count down for me. So we can't get a good patient history.